Today in this video we'll see a situation which can be an issue with any one of us. Now these old age patients may need some other medications including alpha blockers for their prostate problems. So this is one individual who has been taking this medication, and as we can see the pupil is not optimally dilated, and as we'll progress with the surgery we'll find the issues getting difficult. So a capsulorhexis is being performed, and I will also mention that I am operating with my non-dominant hand, and the reason for this is that the steep axis was lying on the temporal aspect of the left eye. So either I had an option of switching my sitting arrangement, or else I could switch to my non-dominant hand to perform the phaco-emulsification surgery. So as we can see the pupil is not very well dilated, so viscoelastic has to be injected repeatedly just to maintain the chamber and also aid in pupillary dilatation. So even the rhexis is a challenge here, which could have been finished just in one swipe. It is also known fact that these patients, if they take these alpha blockers like tamsulosin for even a very short period of time, the effect persists, and these patients may have lifelong floppy iris because of even a short duration of this medication. So this is an important issue when inquiring the patient about ongoing medications and past medications when patient is being planned for phaco-emulsification. Now hydrodissection has been done and we are proceeding for emulsification of the nucleus. The pupil is not at all optimally dilated, and we'll see how it behaves once you touch, and we can see the iris fluttering also because of the incoming fluid flow. And these are all telltale signs that the iris is very atonic, and we'll just see inadvertent fluttering of the iris catches the iris tissue in the phaco tip, and we'll just go ahead and see this in slow motion when this happens. So this is a fluttering, the pupil constricts and it comes into the zone where the fluid is being aspirated, although no power was applied, but still the iris was caught in the phaco tip. Now in a situation like this, the iris gets traumatized and there is a release of prostaglandins which further enhances the pupillary meiosis. So it's a situation where it gets difficult as the time goes by. We can see now the iris is getting prolapsed out of the side port also, and depositing it is a task now, and the pupil is reasonably short. Proceeding for the phaco-emulsification with more determination and rotation of the nucleus has been done so as to aid in proper positioning of the nucleus chunks. This portion of the video is being run at twice the speed. Although the iris flutter and prolapse of the iris, or rather the flowing of the iris towards the corneal incisions, may be a traumatic experience for the iris itself, but at times it aids in the dilatation because the portion of the iris tissue which towards the wound, it causes little dilation of the pupil in that particular segment. We had seen that recently there was one more instance of catching the iris with a phaco tip. Now doing this cataract surgery in such a small pupil is a challenge, but with patience and some dexterity and good foot switch control it can be accomplished. One has to be very careful not to disturb the iris tissue as far as possible. The flow, the vacuum, each thing has to be very much controlled so that only a desired amount of tissue is catch hold of, and there is minimal of surge so that the rest of the tissue which is not supposed to be coming towards the tip is kept away. So this way we have been able to remove most of the nucleus material, removing some amount of epinucleus which is remaining there. and we can appreciate the size of the pupil has gone down reasonably. Interestingly, the other eye was operated recently and it had a corneal opacity in the periphery, and it has recovered fully with 6/6 vision. And in the situation like this, when the iris prolapse occurs, instead of pushing the iris back, the first thing required is to release the intraocular pressure. So just let the anterior chamber have a burp, and so that then the iris will go back by itself. Removing the cortex is also a challenge because a fluttery iris gets caught very commonly in the aspiration port, and a poor dilation of pupil means that you'll have to push the iris away just to visualize the underlying cortex, and this process makes possibility of a posterior capsular tear or anterior capsular engagement quite common. So one has to be very vigilant, very cautious that anything which is apart from the cortex is not caught off, and even if it is caught off, it is not pulled into the center, so as to avoid any PC tear or any zonular dehiscence. Planting the hydrophobic monofocal single piece IOL. There is some cortex still left behind, which I find is safer with presence of IOL. If it is not on the posterior capsule, it can be safely aspirated in presence of the IOL without causing any damage to the posterior capsule. So here we are taking aid of the iris prolapsing towards the wound so as to expose that relevant area for us. Going ahead, removing all possible cortex matter. We can appreciate the pupil, which is hardly 3 millimeters in size now, 2.5 to 3 millimeters, hydrating the wound for a good sealing of the anterior chamber. So it was a difficult surgery which was finished uneventfully and safely. So this is the post-op day 1 picture. We can see some tissue damage of the iris in the temporal part. Rest cornea appears nice enough, transparent enough, and the visual gain is good. Thank you.